think we'll try to at least get started on time and hopefully keep to time today. I'm Julie Graylow. I'm a breast medical oncologist. Also recently joined the board of the Binaytara Foundation. And on behalf of myself and my co-chair Gary Lyman for this conference, I want to welcome you to day 2. We have a packed morning. And so I'd just like to kick it off by inviting Dr. Shaji Kumar up to the stage, and he is going to be the chair of the first session, which is Current Efforts in Reducing Cancer Health Disparities.
Thank you, Dr. Graylow, and good morning to everyone. I would like to just get started by congratulating Binay for this wonderful meeting that he's put together, and it's a topic that's very timely as we face as we have significant progress in cancer, but at the same time face a lot of challenges, especially in terms of the divide in terms of healthcare. Again, I'm Shaji Kumar. I'm a hematologist at Mayo Clinic. My focus is treating patients with plasma cell disorders, and has the unique characteristic, I guess, of one of the few cancers where the racial disparity in terms of its incidence exists. And in fact, it's 2 to 3 times more often seen in African Americans compared to Caucasians. So I think yesterday, the whole day, we heard about the disparities that exist, not only in terms of the access to healthcare for cancer patients, but also very unique facets of how differences exist in the cancer field. So I think the topic of this morning's 2 talks that you're going to hear, again, is on the theme of how can we address the disparities that we see. And again, this takes different shapes. I think the focus for these first 2 talks are going to be one, again, focusing specifically on treating cancers in patients with HIV. And the second, again, adolescents and young adults. And you have 2 wonderful speakers this morning. So first, I would like to introduce and welcome Dr. David Abulafia. He's a professor of medicine and section head at the Hem-Onc section at Virginia Mason Clinic. And he has a long-standing interest in treating patients with HIV-associated cancers. And there's nobody else who better suited to be here this morning to talk about this topic. So welcome, David.
Thank you, Saji, and thank you for the organizing committee for inviting me to speak to you. It's interesting, I picked Martin Luther King and that quote to lead my talk. It's the same quote that Binay did, and then I know Dr. Brawley, if you're in the room, and you had an editorial in JAMA Oncology last week, I think it was, and there was a lead-off with this quote too. And I think that the disparities in cancer care particularly hit people with HIV infection, and I think that's going to be a big focus of what I'm going to be talking about today. And I don't seem to be able to move the slide forward. Okay, great. So I am totally corruptible, and I have no monies to declare except from the AIDS Malignancy Consortium. And I think I love this cartoon, and it says, we're rebooting The Godfather as a Marvel property. And I think I am lucky because so much of the foundation of what I'm going to be talking about has already been covered multiple times yesterday. Disparities in care, how they relate to zip code and race and ethnicity, access to care, preconceived notions about what HIV means and how those people feel stigmatized are all a big part of this. And in our group, the AIDS Malignancy Consortium, we are branching out internationally to sub-Saharan Africa and to Latin America. And so the particular challenges of trying to do research in middle-income and low-income countries was well discussed yesterday, too. This is the broad outline of my talk here, and I think whenever you talk about HIV, it's important to talk about the past and the present, because so much has happened and so much has changed, much of it very positive. But we're kind of like we saw HPV rates were going up in China, one of the discussants mentioned yesterday. We're seeing HIV going up astronomically in certain pockets of the United States, too. So in the past, it was really largely believed that HIV was exclusively a gay disease. And Rock Hudson was quite an icon when he passed away from HIV in 1985. He had done everything he could to protect his identity and not let people know that he was gay, and he got outed out. And that was quite a shock, and it was quite a shock to the American public to see a Hollywood icon deteriorate and literally die before our eyes in a matter of 18 months. 1984 was also the first film that was ever shown on TV in a sensitive way, talking about a young man who has AIDS and goes home and confronts his family with it before he dies. Until Magic Johnson and Kimberly Bergalis came out, it was largely believed that HIV was simply for gay people, and Magic really changed the face of that as an obviously heterosexual male who had been on Johnny Carson like 3 weeks earlier and had bragged that he had had sex with over 1,000 different women and that he had had more sex than Will Chamberlain had. And Kimberly Bergalis was a college student who acquired HIV through tainted dental equipment and died rather tragically too. And then there was the whole issue around HIV and activism, and our president then, Ronald Reagan, would not mention the word HIV, would not mention the word AIDS at all. And many of the patients that I began to take care of were actively thought that the government was out to kill them, and that AZT, the first nucleoside drug, was really there as a government plot to help them die faster. Because when people took that drug, no one ever got better, or at least so it seemed. So in the past, cancers in HIV were identified early in the epidemic and were seen in the context of rapidly progressive disease. Efforts then to give standardized dose chemotherapy, or in fact what was really accelerated chemotherapy because we thought they had such bad cancers they needed more chemotherapy, led to opportunistic infections and actually hastened death for the vast majority. Until highly active antiretroviral therapy became available, it was really hem-onc docs who took care of HIV patients, not just those that had cancer, but these were all patients who had cytopenias and they had weird infections that only the cancer doctors had seen previously. And so it really didn't come until about 1996 when suddenly there were antivirals that were effective, available, that infectious disease docs took over that mantle. And to be sure, at that time, there was just a prevailing sense of hopelessness weighted heavily on all care efforts. And little that we did seemed to really impact on the natural history of the disease. And again, as cancer docs, we had nascent experience with palliative care and with hospice, and this was kind of a natural synergy, at least at that time. Things did change in 1987. The first ELISA test became available, and suddenly we could identify who had HIV before they had AIDS. CD4 counts and HIV viral loads were very much to cancer docs as ultrasounds and CT scans and lab studies are to the rest of us. It allowed us to know where people were in the spectrum of their disease, and it could allow us an opportunity to know how we were doing with treating them. And then early innovations, which were really just sequences of drugs given serially, were changed. And suddenly in 1996, we had cocktails. And the cocktails were 3 or 4 or even 5 or 6 drugs all put together. And that made a huge difference. And quickly, the pipeline for HIV drugs began to expand too. And that made a big difference. And more or less, the quality of life of people with HIV or AIDS was really horrible. They'd be taking 30 or 40 tablets a day. They'd have all the side effects you might expect with chronic illness, but many of them were living. And so that one in itself was a huge victory. Now, fast forward to the present, we have over 40 drugs that are now FDA approved for HIV, and the number of combinations that you can use literally span like 60,000. So they're kind of like hepatitis C. Most patients with HIV they can't be cured like hep C, but they can obtain a complete virologic response. And really, the life expectancy of an HIV-infected person in the US is supposed to rival that of a non-HIV-infected person. And for those who have intolerances to drugs or side effects that prevent them from continuing on current therapy, we have so many different options that we can be really confident that if we get those people into care, we can do a really good job with them. On the other hand, we also have pre-exposure prophylaxis, and that's also made a huge difference on the epidemiology of HIV. If you take PrEP, you can prevent HIV infection in about 80% of people. And if you can take HIV meds, it's kind of the dirty secret of epidemiologists, but you can prevent HIV transmission. We don't like to give that message out too fully because people start practicing unsafe sex, and I'll show you a slide about that in a minute. This slide here is actually the same person, if you can believe it. It's a before and after, and it's a really iconic photo of a man who's gone to many of the world's conferences for AIDS, and he carries this picture with him, and there are many reiterations of this picture, but it's just a shocking demonstration of what new drugs can do for old diseases. Now, the other thing that's really, I think, unique about HIV and cancer is that the cancer teams are different, and that sometimes makes it more challenging for people who don't see a lot of HIV infection. So kind of like maybe transplant-related cancers, you really need a pharmacologist who can help you, get through the drugs and the side effects, and an infectious disease doctor. Many times it's the same with this as well. So, it's a remarkable thing. HIV transmission is falling in the US, but we are getting unprecedented rates of STDs all over again. And we're now almost back to the highest we've ever been. Chlamydia, gonorrhea, and syphilis are just flying off the charts. And it's really interesting as a clinician because a lot of people feel that if they get a lot of people in this area, if they feel they get HIV, it's no big deal. They'll just take one tablet a day. And it's created a lot of risk-taking behaviors. And so even though HIV is transmitted less, we see these really high rates of chlamydia, gonorrhea, and congenital syphilis as well as regular syphilis. And we also see a huge issue around disparities of HIV care. And so Seattle, the HIV incidence is going down, but in North Seattle, we had a cluster of 18 cases of AIDS this past year, of HIV, new HIV infection this past year, and it's really fueled by drug use and injection drug use and risky behaviors and sharing of needles that go with that. In Scott County, Indiana, 2 years ago, 200 people got infected with HIV over a 2-week period. And it's really a testament, and we have a couple people here from Kentucky, and Kentucky is also one of these really hard-hit areas where the opioid epidemic is just devastating communities. And in these communities, HIV, not in homosexual, but in heterosexual populations, is skewing this completely. We had a great talk yesterday from, about the challenges of cancer care in Chicago. And the exact same slides could be shown, and they show the same thing about the incidence of HIV, the inability to get into care or to get care once you're diagnosed in those same very zip codes where cancer care is so problematic. So in 2008, this really super influential article came out in the New York Times, and it basically said people with HIV were living longer, but they had accelerated medical problems, and that they had a concept then which was kind of novel, which was accelerated aging. And the idea is that HIV, like maybe autoimmune diseases, are chronic inflammatory conditions, and even like cancer in that way, and that premature comorbidities evolve over time. And this was basically an article profiling 6 people who were all just in their 50s or 60s, but really were in their 80s or 90s in terms of comorbidities and medical illnesses. And 2008 was also a time when, remarkably for me, because I was so used to HIV and AIDS as a young person's disease, 2008, with the success of antiretrovirals, the median age of a HIV-infected person in the United States was 50. And so that really brings to fore issues around cancers when we start hitting 50, access to care and how it's delivered, and all the challenges that go in with highly active antiretroviral therapy and pharmacokinetics of chemotherapy. The bottom slide here just shows that as people are living longer into the epidemic, and now we're, probably at about a median age of 55. Non-AIDS-defining cancers are by far and away the larger problem than AIDS-defining cancers. And that kind of makes sense. We heard a talk yesterday about acquired mutations and genetic factors, and as well as environmental factors that all take an important role as we age. And, in the context of colon cancer, it's 100-fold higher incidence between someone who's 25 and someone who's 80. And the same can be said for breast cancer and for many of the cancers. And so we're going to hear the opposite in the next talk about cancers in young people. But in the context of HIV, a senescent immune system, chronic inflammation, the covariables of viruses, they all play an incredibly important role in this heightened risk of cancer that we see. So more people are living with HIV, and in addition, more people are living with HIV and cancer. And it's now that cancer is the leading cause of death among people with HIV infection. And in the USA in 2010, and that's the newest information that we have, there was a 50% higher rate of cancers across the board in HIV than they were in the general population. And roughly 50% of all HIV-infected people are destined to develop cancer. In addition, people with HIV or AIDS are 4 times more likely than HIV-negative people with cancer to receive therapy, even though 4 times less likely to receive treatment, even though we say that the treatments are increasingly safe and effective. And the disparity in cancer care is really quite large, and it's really not very well understood in this population. And issues around access to care, co-pays, how people get in and out, which we heard about yesterday, particularly in Chicago, are particularly true with the HIV folks. And I think if you add in stigma of cancer plus stigma of HIV, particularly in Hispanic, Latin America, African American communities, as well as people who have substance abuse, it's really quite a huge issue right now. And so there's a lot of kind of soft research going on right now looking at those disparities of care in people with HIV and cancer. And one of the things that we know is that lung cancer is the #1 cancer killer of HIV-infected people, and that those people are less likely to receive chemotherapy for even cancers that we think, lung cancers that we think are highly curative, like limited stage small cell cancer. Diffuse large B-cell lymphoma, which is totally a curable cancer for the majority of people that have it or are diagnosed with it, HIV folks are less likely to get chemotherapy, and I'll show you something about that in a minute. And sometimes when we look at studies and they talk about disparities of care, it's not that these people don't get some care. In many instances, they get no cancer care at all. And there are still preconceived notions that they're too sick, that the cancers are too aggressive, that the comorbidities or the complications of trying to mix chemo and HIV meds together preclude cancer treatment. And that's becoming increasingly just the opposite in truth. Additionally, there was a survey that was in JCO about 1.5 years ago, and they surveyed medical oncologists and radiation therapists, and about 40% of them said they did not feel comfortable taking care of HIV-infected patients. And those that were HIV-infected, they were less likely to, and they didn't feel comfortable. That was the group that had less likely access to resources like pharmacists or infectious disease docs who could really help co-manage those patients. We heard a really good talk from Dr. Hudis yesterday about what ASCO is doing to promote disparities in cancer care or to dispel disparities in cancer care. And they've taken a good part of that in an effort to trying to level the playing field. And there was a group, a committee that basically came up with guidelines that were published in JCO, and there have been other articles in JNCI just mentioning the importance of treating these people in the same way that we treat non-HIV infected patients. And I'm not even talking about preconceived notions about this, that, or the other thing. It's just the chemo works just as well in this group as it does in other groups. And I think that effort has been really important because the NCCN has now come out with guidelines. And I think as oncologists, we do a pretty good job if we can go to the NCCN, if we don't know our way real well, and follow templates and guidelines to help move us through. But there have never been templates for HIV-infected patients. And now we have standard guidelines for Kaposisarcoma and for hematologic malignancies. It's made a big difference, or at least I think it's going to make a big difference. Now, we heard yesterday about real-world data and how it could potentially be leveraged to give us a lot of information. There's a physician, Janakali Murami, who was working at Maimonides Medical Center in the Bronx, and that's a group that works on the AMC, and they've had a very difficult time accruing lymphoma patients to clinical trials. So Murali and I and a fellow that he works with had looked at their data over a 14-year period, and during that period, 80% of patients who were potentially eligible for a protocol were not enrolled. And the reasons were mostly because of archaic information, like if you have hepatitis B or hepatitis C, you can enroll in a clinical trial. So I think ASCO's efforts to try to level that playing field by saying that we need to have more thoughtful inclusion and exclusion criteria are particularly important. Virtually every clinical trial that's done by pharma has a codicil that says if you're HIV infected, you can't go on this trial. It's same like brain metastases and other things. So we really need to develop better protocols and more thoughtful protocols when it comes to barriers and how we limit those people. Now, the other thing that is, I think, almost impossible not to talk about in this climate is just the change in administrations. And you can see on your left, I think, Obama and the initiatives that were put into place during his presidency. They were really far-sighted, they were really important, and they had global implications about the world efforts to minimize HIV infection by 2030. Now, at his State of the Union address, Trump came out and said we were going to eliminate HIV by 2030, or new transmission of HIV by 2030. But I think there's so many question marks about the administration that has been so hampered by political unrest, a president who tweets 20 times a day about the Mueller investigation. It's really a challenge. And so even though he's talked about developing a program around AIDS and HIV, nothing has really come of it, and there's very little expectation among most of us that he has any infrastructure in place. Most of the people who served on his HIV committees were fired. Now, I got this other slide on the right from a friend, and it says Suavidad sin fronteras, and it's softness without borders. And I just thought it was really funny, so I threw it in there. So among the unique things about cancer and people living with HIV is just that incredible connection between co-viruses. So HIV is a virus that reduces immunosuppression, or maximizes immunosuppression, reduces T-cell surveillance. And then you have these oncogenic viruses that really combine with HIV and create kind of a perfect soil for the development of cancer. Interestingly, I went to India for the first time about 10 years ago. It was right before generic drugs became, or before India started manufacturing their own drugs for HIV infection. And at that time, we were at a conference and someone presented a case report of Kaposisarcoma and HIV infection. And it was like, it was a case report. There are no cases of Kaposisarcoma in India at that time. Now, if you go to sub-Saharan Africa, of course, Kaposisarcoma is terrible and it's out of control, and it affects children and babies, and it moves all the way up the spectrum. And it really has to do with HHV8 and where the epidemiology of that virus is. But we know that roughly 35 to 40% of lymphoma patients have EBV as an oncogenic driver. And then we heard a lot yesterday about HPV and the importance of that in driving cervical cancer. In the non-AIDS-defining cancers, which are anything but KS, cervical cancer, or intermediate or high-grade lymphoma and primary CNS lymphoma, you can see on this slide the various viruses that are really important for that. And then yesterday we also heard a really great talk from Dr. Jha about environmental factors and how they influence cancer promotion. And 60% of HIV-infected people in the United States smoke, and they smoke a lot. And when we add in other co-problems such as alcohol, and then our rising epidemiology with head and neck cancer, it's kind of a perfect storm. And so efforts are really being put underway now to develop, smoke cessation that's targeted to the appropriate populations and in a message that can resonate. So I thought it was really interesting yesterday about hearing about e-cigarettes and how those are being used. And I know in my own practice, we of course promote them and tell patients it's better than smoking a cigarette. But the same people who make e-cigarettes are Philip Morris and the other drug companies, and they're definitely looking, even though there may not be the good data about it yet, to graduate people, and I'm talking about young people, back to smoking as they get older. So just a minute, I think I have 2 slides on lymphoma and a couple slides on KS, and then I want to talk a little bit about anal cancer screening. Lymphomas are the second most common malignancy in HIV infection, and it's kind of a combination or a gamish of diminished immunosurveillance, polyclonal B-cell activation, oncogenic viruses, and cytokines out of control that all kind of lead to a lymphoma. The general remarks would be that it's usually of advanced stage at time of diagnosis, usually associated with fevers and night sweats, and that there's some really good news coming up in a second, and that's that the incidence of lymphomas is falling rather dramatically. I used to see a patient with primary CNS lymphoma probably once every 3 weeks in my practice, and I can say I don't think I've seen one case in the last 3 years. That has been such a profound difference. But in that yellow there, I've bolded out and just say that we now know that these patients should be treated in the exact same way as people who don't have HIV infection. And we made a lot of mistakes over the years trying to give too much or too little chemo. Really now with heart, we do have the same, and we look at those people really very similarly as non-HIV infected patients. And so at least in the HIV context, our EPOC, kind of a cumbersome infusional therapy, would be a standard, and those patients usually get prophylaxis to prevent leptomeningeal disease. But there's a lot of data, City of Hope, Fred Hutch, others have looked at it and said autologous stem cell transplant is also a very viable option for those patients with relapsed disease. There's a lot of interest right now in doing the same things for these patients as others. So less chemo may be better than more chemo, particularly those with early stage disease. And there are a lot of newer drugs that are on the horizon that can target this particular group. It seems ridiculous to talk about CAR T cells in this audience, but that is kind of the next area for this group. And this is a study that came out of Lancet HIV last month, and it basically just looked at the drivers of lymphoma in an unusually large cohort of, or multiple North American cohorts of 100,000 people. And it basically said people who have high levels of HIV viremia and have low CD4 counts are uniquely at risk for lymphoma. And beginning in 2016, we have now standard recommendations that all people with HIV infection should get HIV meds. And in that context, less and less people are going to have low CD4 counts. They're going to be rescued early. They're not going to have sustained viremia. So the rates of lymphoma that we're seeing that are already declining are going to decline dramatically further. In Seattle last month, we had CROI, which is the big ID meeting for HIV. It's a world meeting. And they presented what was called the London patient, a man who had relapsed lymphoma and ended up going through a transplant and is reportedly cured of his HIV. And he's the second patient. The first one, Timothy Brown, who's in the middle of that slide there, actually lives in Seattle. He was called the Berlin patient, and for many years, no one knew who he was. And about 5 years ago, he kind of announced to the world that, hey, I'm the Berlin patient. And now at Harborview's AIDS clinical trial unit, he often comes to community meetings as kind of a proof of principle that you can be cured of HIV. In his context, he had acute leukemia, and he underwent 2 transplants. The first one didn't work, and then he went to a second transplant. And much like the Berlin patient, he got, by coincidence, bone marrow from a person with an unusual CCR5 delta 32 gene mutation. And it turns out that there are sex workers in Africa who have sex with anywhere between 50 to 100 different people in a day, in an area that has 30 to 50% HIV endemic rates, and they never get HIV. And it's because they have a genetic mutation, a co-receptor on their cell surface, that makes them relatively impermeable, or the HIV virus impermeable to entering in. So both these guys were lucky. I think it's about 2% of the population, and by weird coincidence. It's not a viable strategy, obviously, to cure cancer, but or cure HIV, but it's a viable background when we think of CRISPR and editing, and we think of now hemophilia and sickle cell as very treatable and probably curable for a limited group of people. It's another platform for us to look into. So Kaposisarcoma, by far and away the most common. And for me in my practice, KS is a really easy disease to treat. I never see it anymore as kind of like what we see here, which was what I was used to. But this is what we see routinely in Africa. And conventional chemotherapy doesn't always work well enough for these groups. And there's a lot of questions on how best to treat these patients. Chemotherapy has a role. A drug like liposomal doxorubicin can be a pretty cheap drug when made generically and does have applicability in third world countries. It's much less toxic than conventional adriamycin. The thing that really interests me is that there's, as we move into third world countries, and we're not talking about different treatments, but what maybe we think of as practical treatments. Well, it turns out beta blockers have been used in pediatrics to treat angiomas at birth, and there's a lot of interest in giving propranolol, and there's going to be a clinical trial in pediatric KS that's rolling out in sub-Saharan Africa. And what a great thing that would be. What a cheap drug, relatively effective, certainly not very toxic, and that'll be interesting. There's also a lot of interest in diseases that are seen more in Africa than we do see here, which is immune reconstitution inflammatory syndrome. Sometimes patients start on their HIV meds and their immune system takes a kind of a hit upward, and their KS proliferates like crazy, and it becomes a life-threatening problem. And there's this what's called KICS, or cytokine storm syndrome, that goes with it. And there's a lot of interest, particularly in Africa, in trying to figure out how to tampen that down. The usual way is to give steroids, which are often problematic in this group. So as we move forward and we talk about the incidence of cancers, and you can see here where KS and anal and NHL and Hodgkin's disease fit into this. And then here are the non-AIDS-defining cancers. And I think what's worth highlighting here is that, by the year 2030, prostate cancer will be the leading cause of cancer in HIV-infected people. And so really this epidemiology of what kind of cancers we're expecting are going to change. Oddly, right now, breast cancer and prostate cancer are less represented in this group, and whether that's because of reporting issues or whether there's a real biological reason, we don't know. But statistically, and as these people age, these are the cancers that we're going to be seeing. So I mentioned that there are now guidelines to help us, and I think that's going to make a really big impact because we know that people with HIV don't get the cancer care they often deserve. Sometimes it's because of access issues. I think that's absolutely enormous if you work at Cook County Hospital. But it's also ignorance on the part of docs who don't see those kind of cancers frequently in terms of what they feel comfortable with. So having guidelines is a big help in that area. And having HIV meds that are really effective, that are remarkably non-toxic now, is a real game changer in this disease. And, the bottom line I think I put on that last bullet there is that these patients should receive and should be offered the same treatment we would give HIV-negative people. So this is really, again, kind of an affront to a group like this when we're talking about cancer health disparities, and we're talking about CAR T cells or checkpoint inhibitors, things that cost $100,000, $150,000 for courses. But when we started looking at immunotherapy in the context of HIV, we were very worried, and it took a long time to develop a clinical trial because our reviewers were concerned that there'd be a heightened risk of autoimmune diseases and other phenomena. And now we have enough data to know that people with autoimmune diseases don't get flares of their disease on checkpoint inhibitors. And we also have enough data, this was from JAMA Oncology, and I think it was 73 patients who had an assortment of different cancers and who got immune-based therapies. And they respond in the same way that HIV-negative people do. So again, just a way, not to say everyone should get this, obviously, but a way to say that the treatment spectrum should be level. So I'm going to try to show a video before I end this talk. And one of the big issues with HIV cancer screening, and again, making a distinction between screening and prevention, but cancer screening is that there's very little in the way of data in terms of how these people do and what are the best methods to undertake cancer screening in this population. And so a lot of the recommendations that we have really are just kind of default. It's like, well, if you're HIV positive and you're 45 years old or 50, you get your mammogram, and when you hit 50 or maybe 45, you get your colonoscopy. And for those with a strong family history, definitely get a PSA and a digital rectal exam. But we really need to understand better why these people don't get screened nearly so often. And again, a lot of the issues are the ones that have already been talked about abundantly in this conference. It's just with one more additional stigma, one more huge variable, and that's HIV infection. The AMC is going to be doing a lung cancer screening project, and of course there were no HIV positive patients in the lung cancer screening registry study. What is it? If you live in Ohio or Kentucky and you have a lot of pulmonary nodules, are you doing more good by screening those people or not? The false positive rate is an issue. I think the other thing that's really interesting for me is this ANCHOR study, and ANCHOR is the brainchild of a guy named Joel Pilevsky, who's an infectious disease doc in San Francisco, and he's made a career out of talking about the link of HPV to anal cancer. And the anal mucosa is embryologically just like the cervical mucosa. HPV is the driver, 16 and 18, just like the cervix. And an anal pap looks exactly like a cervical pap under the microscope, and the pathologists read it the same. And so we already know that cervical cancer screening prevents cervical cancer, even though there was never a randomized trial to do it. Well, anal cancer screening, the government has said we need to do a study to know if it's appropriate. And it is a cumbersome thing to do anal cancer screening. The study that is being done, which is the ANCHOR study in Seattle, and Virginia Mason, Polyclinic, Harborview are participating, but it's a nationwide study. It involves 5,700 HIV-infected men and women across the U.S. over the age of 35. And the question is, if you do high-resolution colposcopy directed at the anus, can you prevent anal cancer by screening and treating high-grade disease? So I have my fingers crossed. This is going to be my last slide. And can you turn that on from the back by any chance? Thank you.
We made this video to help women like you who are HIV positive learn more about anal cancer screening and about taking part in a research study.
Somebody do an anal pap test. Anal cancer is becoming more and more common, especially with HIV positive women. They get cancer of the cervix, which we already screened for, but then there's a chance that we can get cancer of the anus.
Anal pap smear, for me it was like, behind there, something going in there? My name is Delphine Masongo. I'm from Kenya and I'm 40 years old. I was diagnosed with HIV in 1992 and I was living in Nairobi, Kenya. In Kenya, I wasn't told that I was being tested, but a few years later I lost a child because she was breastfed. And that's when I knew that I was living with HIV. When I got here, I got a whole team of doctors. The biggest thing here is the one-on-one. But every time my nurse suggested, can we try the anal pap smear? I still said, no, I'm not ready. Maybe next time, I'll think about it. So when I was having the vaginal pap smear, she said, can we try it today? I said, oh, okay. Let's do it and get over with it. So that was the time I agreed. And it was just a swab. I didn't feel anything. Still, all I thought was cancer on top of HIV. No. But I think it's good to have yourself tested for the cancers that we are trying to, to avoid. It's really up to you. This is your life, to take care of yourself.
My name is Anne. I'm active in recovery. I do a lot of 12-step meetings, and I get regular medical care, which is something that I had just left out of my life prior to getting this diagnosis.
Hi, Anne. Nice to meet you.
Hi, Dr. Steyer.
Hi. I understand that you're here to have an anal pap and an anoscopy. Is that correct?
Yep.
Any idea why you're having this?
From what I understand, it's because I have HIV, and that makes me at higher risk for developing anal cancer.
That's exactly right.
Okay.
Exactly right.
But I don't know about
Anything else?
anoscopy.
Okay. That's why I have our lovely little model here. This is the vagina. This would be the bladder and draining out where you would pee. And this is the anus on the bottom.
Okay.
So basically there are 3 holes, and we're going into the bottom hole.
All right.
The very first thing that we do is an anal pap test.
Is that like a regular pap test?
No, it's no speculum involved. We just use a Q-tip.
Well, that's not so bad.
Yeah, exactly. So what the Q-tip's going to do is go in the anus about so far, and then we rub it around and bring it out. And we'll see what the cells look like from that. Now, I always have to say what we do if it's abnormal, and that's what's called an anoscopy, or a high-resolution anoscopy.
Okay.
This is an anoscope. Clear plastic, goes in about this far. Use a lot of lubricant that has a bit of numbing medicine in it.
Okay.
Okay. And what we're going to do is to insert this and take this out. Then I put some gauze with some white vinegar on it in
And
there.
you can actually see in there.
And then I can see in there.
Okay.
And then we just look around very carefully with the light and a special microscope. Basically, I'm looking to see if I see anything that looks like a wart, looks like it could potentially be something that could turn into cancer, or something that looks like cancer.
Okay.
So those are the things that I'm looking for.
Okay.
Okay. If I see any of those things, what I'm going to do is to take a little biopsy. And biopsy is taking a little piece of tissue. I give some numbing medicine beforehand, and then I use a special instrument. We take out a little piece that's about the size of a sesame seed.
Okay. Is there going to be bleeding with that?
There may be some bleeding with that. I usually take care of the bleeding at the time of the procedure, but sometimes afterwards you can get some bleeding as well.
Okay, so that's all there is to that.
That's all there is to that.
When you next see your doctor, you can ask about getting an anal pap test. Right now, we are also conducting a research study to help doctors find the best ways to screen for anal cancer.
Without having women participating in the research, we won't be able to find out whether we should be screening for anal cancer in HIV-positive women and how we should screen them for anal cancer. We think that we should use an anal pap test, but we don't know that this is the best test to use. And only by having women participate, by saying that they are willing to be tested in a variety of different ways, can we figure out what the best way for testing actually is.
As part of the research study that I decided to participate in with Dr. Steyer, I've had the anoscopy procedure done several times now. And so as with, so by now I'm kind of used to it. So it's kind of like a routine thing for me. But definitely the first time that I had it, I was really anxious about getting it done. I did not think that it was going to be at all pleasant. And it's not pleasant, but it's not really that bad either.
How are you doing today?
I'm doing pretty well. It's definitely empowering to get treatment for the conditions that I have, but also to know that the information that's gleaned from the research that I participated in is going to help people in the future.
Can you see a last slide there, or is it? Yeah, okay. So just a couple quick points to end, and mention that the cancer risk increases with age. The burden of cancer is large, and as these folks live longer, their cancer risk will continue to accelerate. And it is now the leading cause of death among people with HIV infection. Lifestyle choices are increasingly important. Alcohol, smoking, all kinds of things that can increase your cancer risk. Obesity is maybe a mild one, are all super important, as are the oncogenic viruses and how they're transmitted. People with HIV and cancer are less likely to get standard chemotherapy and treatment that our non-HIV infected people do get, and it's really important for us to begin more research into understanding what are the barriers particular to that specific group. And then emerging cancers need attention too. Anal cancer is a big one. We hope the ANCHOR study will be a huge success. It's about 3/5 of the way to completion, so it's already collected over 3,000 participants. And there have been a number of cancers identified. We just haven't broken up the data yet to know to what degree this is going to make a difference. And then screening and prevention treatments are, of course, screening and prevention strategies are really important in this group. And with that, I'm really sorry. I realize I just way overshot, and my apologies.
Thank you, David, for that wonderful talk. We will leave all the questions towards the end. So it's my distinct privilege to introduce Dr. Mark Lewis, whom I have known as a fellow in the Hematology Oncology program at Mayo Clinic. Obviously, we didn't quite convince him to do hematology. Axel won that battle and made him do gastroenterology. So he is the director of GI Oncology program at Intermountain Healthcare, and is also the co-chairs the SWOG Adolescent and Young Adult Oncology Committee. Welcome.
Good morning. So yes, I would be remiss not to acknowledge that in terms of my pedigree, many of the people that train me at Mayo are here in the room. And yes, Shaji, you're right that ultimately Axel won my allegiances and I went into GI medical oncology. But I want you to know the things that you taught me in hematology, and specifically about myeloma, are not forgotten. So all your teaching was not in vain. So let me cover the salient points that I remember, okay? So high calcium, bad. High creatinine, bad. But before you get lulled into a false sense of security with that pattern, low hemoglobin, bad. So yeah, go figure. So I don't know how you keep track of all that. To me, the gut's just one big tube that either leaks or gets blocked. It's very simple. I'm basically a plumber, but not paid as well. So that's what I do now. Yeah, can I find the slideshow here while I'm doing my stand-up? Thanks. So what I'll be talking about this morning is a subject that's near and dear to my heart, and arguably, I think, a healthcare disparity globally, but also here in the US, and that's adolescent and young adult oncology. So first, some good news before we get to the more sobering statistics. You know, on the whole, the rate of cancer appears to be declining, and I know Dr. Brawley is in the room, and you know, a lot of this happened under his leadership at the American Cancer Society, and he's to be really thanked for that. However, there's this very worrisome gulf in AYA, or adolescent young adult oncology, and for various reasons in the United States, we've chosen to define that age range as 15 to 39. Now, there are other countries where the age range is defined more narrowly. So, for instance, in the UK, where I'm from originally, the classic definition is 18 to 24. And that's due to various reasons, including the way they structure their care around specialized inpatient units. But the reason I think the definition holds water, at least here in the US, is you can see here on the graph this very worrisome dip in survival that happens between adolescence and young adulthood. And you can see it there also. And in fact, survival rates in this demographic have really been stagnant since the mid-1970s, despite all the other progress that we've made in oncology. And even in the 30 to 34-year-old group, particularly in men, survival is getting worse, not better. So clearly we have a big problem in our hands, and we need to aim to understand it better. Dr. Archie Blyer is considered the godfather of AYA oncology in this country. And this is a quote from him. And I don't often read quotes, but this one I think deserves to be recited. So the most disturbing finding is the lack of progress in survival improvement among older adolescents and young adults in contrast to all other ages. Whereas the diagnosis of cancer in this age group used to carry a more favorable prognosis relative to cancer other ages, current survival improvement trends portend a worse prognosis for today's young adults diagnosed with cancer. Now, this may be a partial explanation. I know there's a lot of data on this slide. If you look at the top graph, the dotted purple line is showing you the cancers that are most prevalent in the AYA population, and then they're listed in color in the graph below. And what's really, I think, quite alarming, and maybe even a partial explanation, is the drop-off in trial accrual, which is that red line on the bottom. So proportionately, the people in the AYA demographic are less likely to be enrolled in studies. And this has also been described as the accrual cliff. What I'm showing you here are sort of 5 of the classic adolescent young adult cancers: ALL, AML, CNS tumors, Hodgkin's, and osteosarcoma. Now, the red lines on these graphs are their likelihood of being accrued to clinical studies. And I think, honestly, as an adult oncologist, I think we bear some of the blame here. I think our pediatric colleagues, particularly in the children's oncology group, are very trial first in their thinking. When they meet a patient, it's almost reflexive that they think about protocols before they think about standard of care. Arguably, putting someone on a protocol for pediatric cancer is the standard of care. I don't think in adult oncology we're quite as good about that, making it a habit. And I think these patients really fall into a gap where the pediatricians may not feel entirely comfortable taking care of the young adults, especially as they get into their late 20s and 30s. And then the adult oncologists may not really feel comfortable taking care of patients who are literally just leaving their teenage years. And I think they kind of get caught betwixt and between. ALL is really, again, a classic prototypical AYA cancer. And what I'm showing you here, the red line is 5-year leukemia-specific survival. And you can see it dropping almost in parallel with the likelihood of being enrolled in trials. And this is actually a particular tragedy because we've recently learned through work from Dr. Mark Litzo at Mayo and many others about the benefit of taking on a study at the time, CLGB 10403, taking a pediatric inspired ALL regimen and applying it to young adults up to the age of 40. This was actually a trial that was enrolling when I was at Mayo as a fellow. It enrolled almost 300 patients in this age group and showed that not only can they tolerate a pediatric regimen, but their survivals are greatly improved. However, we're only going to make that progress by really studying intensively these young people and seeing how they do with pediatric versus adult regimens. Part of that work, and I have to admit my loyalty here, I came straight to this meeting from the SWOG research meeting in San Francisco. I know many of the rest of you did as well. A lot of this work's happening not just in SWOG, but through the NCTN network, of which SWOG is just one sort of part, spoke on the wheel, if you will. Just a quick word of background about SWOG, because I think that the nomenclature is a tiny bit confusing. So SWOG was actually founded at MD Anderson in the 1950s by a pediatrician who was interested in studying leukemia drugs. As that work expanded out, it basically moved into the region of the American Southwest, so it was the Southwest Oncology Group. Now, however, SWOG spans the entire nation, so much so that it's actually not an acronym anymore for anything. It's not the Southwest Oncology Group, it's just SWOG. It's very zen, just SWOG. And it contains over 1,000 research institutions, and I've been very lucky in the last several years to be the chair of the AYA committee, which is not disease-specific, but which is a research support committee, and our goal is to provide AYA insight across our cooperative group and into others. One thing that's really kind of interesting is I think that AYA patients are the incidentalomas of the adult cooperative groups, meaning that they've been enrolled in trials from SWOG and ECOG Akron and the Alliance for years, but no one or few people have actually taken the time to look specifically at their AYA subsets. So what we did in SWOG was we said, well, gosh, we've actually been collecting data on 18 to 39-year-olds for years because sort of our default youngest age of inclusion is 18. There are, of course, examples of trials in, say, prostate, where the youngest age is 60, but for the most part, SWOG's been enrolling 18-year-olds for ages. And so we decided, well, what would happen if we took this demographic and sort of looked at our experience, again, not histology specific, but histology agnostic. So we examined the initial registrations of patients between 15 and 39 from the therapeutic trials that we'd coordinated, phase 1 through phase 3, over 15 different disease types between 93 and 2017, so a quarter-century experience. And then we compared the accrual patterns to the older patients, 40 and up, and also to the corresponding US cancer population in the same age demographic derived from census data in SEER. Just briefly on the statistics, we did actually think about gender specificities. Of course, cancers like testis are only going to happen in men. And then again, we were comparing against census and SEER. So here's what we found. So SWOG as a whole, in this 25 years with these 15 diseases, accrued just under 80,000 patients who were adult, of whom roughly 10%, 7,700 or so, were AYA. Now, over the same time period, there was less proportional enrollment to clinical trials in the general US cancer population. Now, neither of these fractions should be satisfactory to us. We gave ourselves the lightest pat on the back that we were, quote-unquote, over-enrolling at SWOG, but we really weren't. And that's obviously given us a push to move forward. One thing I think is interesting, though, is when you break down the histologies, it might not be what you think in terms of the #1 most prevalent AYA cancer in SWOG. So here's the top 3, 2 of which I think are sort of classic AYA diseases, leukemia, lymphoma. But #1 with a bullet was breast cancer. We'll talk about why that is in just a second. You'll notice that melanoma and colorectal actually come in at 4 and 5. And I'm going to spend the latter half of my talk actually delving into the problem of colorectal cancer in young patients. Sarcoma is actually way down there at number 13. Now, the caveat here is we were looking at trial enrollment. Okay, sarcoma is a tricky disease to study, and in SWOG, it's actually kind of struggled to find a foothold. It's sort of migrated around. It usually actually lives in the Rare Diseases Early Therapeutics Committee. So it may just have been that our trials for sarcoma patients were lacking at the time. But here's the big 3. And again, breast cancer wins in terms of, or loses, how we look at it, in terms of being the #1 prevalence. I think this is just a case of a small fraction of a large number still being a very large number. And in SWOG, which has kind of been very forward in its breast cancer trials, it's not particularly surprising that some minority of the overall breast cancer population would actually form the majority of the AYA patients. So these 3 disease types accounted for just over 3/4 of all of our AYA enrollments in SWOG. So let's take an even bigger step back and compare that to the SEER data. So a couple of caveats. #1, this is looking at 15 to 29-year-olds. So again, there's not even in America perfect agreement on how to draw the AYA boundary lines. So this is looking at slightly younger folks, right? It's looking at 75 through 2000, and this is looking at incidence, not clinical trial enrollment. So here, the big 3 from SWOG, breast, leukemia, and lymphoma, don't account for 77%. They account for about 31% of all of these cancers. And then the one I wanted to really pull out and talk about more, and this is where Axel's influence is going to be obvious on me, is GI cancer. So I've actually now dedicated my career to GI oncology. I'll explain my selfish reasons for that in a little while. But I'd want to specifically drill down and now talk about GI and AYA. So this is a really alarming trend, which is that we seem to see the needle shifting, not in a good way, towards incidence and mortality increasing for patients under the age of 50 when it comes to colorectal cancer. Now, I know these graphs are small. The column on the left there is showing you incidence and mortality in patients aged 20 to 49. The middle is 50 to 64, and the right is 65 and up. And basically, over the same time period that I'm showing you, the incidence of colorectal cancer above the age of 50 dropped by 32%. The mortality dropped by almost exactly the same amount. So the graphs for the younger people are really heading in the wrong direction. This has been very newsworthy. That top headline there comes from the New York Times. And regardless of your politics, I can assure you, unfortunately, this is not fake news. And then it was seconded by CNN and CBS. And what was prompting this sort of wave of interest back in 2017 was largely this article published by Siegel and colleagues in the JNCI that year. And again, this is actually showing you the annual % change in incidence by age and birth cohort. I know it's small. The red box is delineating, again, the folks in the AYA categories. And if you just kind of really take a 30,000-foot view, you can see that their trend lines are coming up, whereas all the other age groups are, at the very least, plateauing, if not heading down. And what that really means is that patients born in 1990 have double the risk of colon cancer compared to what patients born in 1950 would have faced at a comparable age. And then I'll also argue, although I just said at the beginning the gut's very simple, it's actually multiple different organs put together, even the luminal tract. And so rectal cancer is even more pronounced. So patients born in 1990 have quadruple the risk of rectal cancer compared to what patients in 1950 would have faced at a comparable age. So again, site matters. And a lot of young onset colorectal cancer, probably about 80% plus, is happening distal to the splenic flexure. And so this is particularly an area of interest. And we'll talk more about sidedness in a minute. I was talking to Dr. Jha last night at dinner, who I enormously respect as both a physician and author, about Siddhartha Mukherjee and how he seems to be kind of a superhuman in his ability to take care of patients, run a lab, and just casually toss off Pulitzer Prize-winning books. This is, I think, a perfect bookend to The Emperor of All Maladies. I think they're best read together in series. And he has provided me with a formula that I have used in clinic pretty much ever since I read it. So I think one of the toughest questions I face, and I'm sure many of you in clinical practice do too, is when the patient looks at you just with big pleading eyes and says, why did this happen to me? And I don't know if there's really a satisfactory answer to that, and in fact I know there's not. However, to make it less abstract and a little bit more framed intellectually, hopefully not coldly, I've often cited this formula. And this can also be used to dispel stigma and shame, because Axel and I were talking earlier about the conversation on Twitter. The internet is both the best and the worst thing that's ever happened to medicine, in my opinion, because it's the best thing when you have a wonderful dialogue with your peers and colleagues and patients. And it's the worst thing when you see this just spewing geyser of vitriol. Earlier this year, I engaged in, I'm ashamed to say, I got baited by trolls who were shaming cancer patients. And one guy in particular, whose handle was called Hyper Carnivore, said that all cancer patients deserved cancer because of making poor dietary choices. So my retort to that was actually this very formula. I said, hey, listen, mate, there, but by the grace of God, go you, because Mukherjee says our phenotypes, and specifically here we'll talk about cancer, are our genotypes plus our environment plus our triggers, which may well be lifestyle choices, plus chance. This is one big lottery. And so when young people in particular come to me and are, why did I get colorectal cancer under the age of 50, a lot of it, I go back to this. So in terms of genes, this is not even an exhaustive list of the reasons that genotypically you might get early onset colorectal cancer. Many of them are familiar to folks in this room. Lynch syndrome is well known. Classic and attenuated familial adenomous polyposis. This is where your gastroenterologist goes in and sees the colon carpeted with polyps. If you have FAP and your gastroenterologist doesn't see your colon carpeted with polyps, you need a new gastroenterologist. Peutz-Jeghers is on the list, juvenile polyposis syndrome, defects in repair in terms of polymerase proofreading-associated polyposis, Cowden's disease. But here's the thing, and Axel might agree with this too. In the last, say, decade in colon cancer, I think one of the big takeaways has been right versus left. So the right colon really is different from the left colon. And David mentioned embryology in his talk too. If you think about it, so the hindgut gives rise to sort of the colorectum up to some point in the transverse colon, and then that's actually anastomosed, if you will, with the midgut. So I think even embryologically, they're kind of two different organs that get joined together. But what's really interesting is if you said, okay, well, what if this rise of colon cancer is because of genotype, and we're just seeing more Lynch and FAP, for instance? Well, if that was the case, particularly with Lynch, you'd expect a trend for more right-sided tumors in these young folks. And that's actually exactly what you don't see. You see most of these tumors happening on the left side. So for instance, in this particular graph, if you added up everything from the splenic flexure down, it'd be about 80%. So again, Lynch and FAP can only be part of the problem. If you stand back and look at things like microsatellite stable or unstable, and even chromosomal stability versus instability, roughly half of the young patients with this disease, when you molecularly profile them, have intact chromosomes and microsatellites. So that can't be the whole explanation. Well, what if it's a case of common disease with rare variant? And so the idea here is maybe this is polymorphisms that are having not just an additive but a multiplicative effect. So maybe sporadic early onset colorectal cancer is multiple rare variations in genes converging. And these might independently be susceptibility factors that are then together conferring a moderate but significant increase in cancer risk. You may have seen this Swiss cheese model. This actually comes up a lot when talking about medical error, how everything just aligned exactly the wrong way. And I kind of wonder if that's the same thing that's happening here with these sort of individually lower risk polymorphisms, but again, they align in just the wrong way for the young patient. Every cancer patient, or almost every cancer patient, comes to me wants to know their stage, right? That's one of the kind of, I think, fundamental questions. Unfortunately, even though these patients have a lesser comorbidity index, they tend to be found at a later stage, and there's all kinds of things we can infer here about lead time bias or its opposite, but there's roughly a 1.5-fold relative risk of metastatic disease at diagnosis for folks under 50 versus folks over 50. So if we're going to make an impact, well, we'll talk about screening as prevention in a minute, but what about, back to the Mukherjee formula, what about the triggers and the environmental things that we might be able to modify? So the real issue here is, yeah, an ounce of prevention is a pound of cure, but what do you prevent? So there's lots of different theories, none of which I find individually that compelling, with the possible exception of microbiome, as to why these people are having this happen to them. So is it the obesity epidemic? My wife's a pediatrician. There's absolutely an obesity epidemic in young people, but is that then somehow translating into more cases of colorectal cancer? Is it smoking or alcohol use? Is it something in the diet, particularly with charred meats? Or is it the microbiome? So again, I mentioned my wife. One of her causes, if you will, in her clinic is judicious use of antibiotics. And she is under enormous pressure from parents to put children on antibiotics, whether they have a bacterial infection or not, typically not. So maybe the overzealous use of antibiotics, particularly in childhood, has altered the microbiome and allowed potentially oncogenic strains of, say, Fusobacterium to emerge, dominate, and then cause oncogenesis. We will see. So HPV, does it play a role in CRC oncogenesis? Well, there are some case control studies that suggest colon cancer is 6 to 10-fold more prevalent in patients with HPV co-infection. So maybe it's a passenger there. However, just here at Fred Hutch, not far away, they tested about 550 colorectal tumors with no detectable HPV-18 DNA and only 2% HPV-16 positivity, so some of the two main oncogenic strains. So I personally don't find the HPV argument that compelling. And then the bigger question at a conference like this, if we're talking about the kind of national and even global scale, well, since this is such a problem, or I think it's such a problem, should we be screening earlier? Can we take advantage of this biology by which adenomas progress to carcinomas? Can we intervene earlier in that sequence? Now, let's say, for the sake of argument, that we carried out the recommendation of the American Cancer Society to take average risk patients and screen them with colonoscopy, not at 50, but at 45. That's been a recommendation now for, almost 11 months. Now, that's going to increase volume, right, and it's going to increase cost. And it would add roughly 20 million Americans to the eligible patient population for screening colonoscopy. Colonoscopy is not entirely benign. We saw the video about anoscopy. Colonoscopy is certainly more extensive than that. And it does carry a complication rate. Now, how do you define complications? Well, if you're looking at perforation, bleeding, post-procedural paralytic ileus, the complication rate is probably right around 2%, or 23 complications per 1,000 screens. Now, one tiny grain of salt there is this complication rate is derived from the older population. One might postulate that the younger patients are less likely to get these complications. The US Preventative Services Task Force has done their own work on this, and they've done life years gained modeling, and they said we find insufficient benefit for screening age 45. So a little bit of a difference of opinion there with the ACS. But keep in mind, I think women's health here is actually quite a bit ahead, and everyone has a colon, not just men or women. So we're so good at, arguably good at screening for cervical cancer. I wonder if we can't apply the same logic, doing a lot to save thousands of lives of women from cervical cancer, or if we can't apply the same logic here. So perhaps benefit of earlier screening, in fact almost certainly is in the eye of the beholder and in the eye of the payer. So again, we can intervene here or exploit biology of, well, when do people start getting polyps? So when then does polypectomy become of some putative benefit? And what this graph is showing you, believe it or not, is that by the age 45, roughly a quarter of patients will have a polyp that could then be removed with colonoscopy. Now this is admittedly quite a complicated graph looking at various time intervals and ages of initiating screening. And what I'm going to try to highlight for you there in the purple box is, okay, well, what if we did start screening at 45, and so that red arrow is pointing to a hollow purple box showing you the life year gain of screening with colonoscopy at 45. And basically, by going from 50 to 45, it yields an additional 28 life years gained and requires an additional 827 colonoscopies to do so. So that's the number needed to screen here. Heinz, Josef Lenz, and others at USC have done a very interesting comparative effectiveness analysis where they were looking at life years gained and number of cancers prevented. And basically, at the bottom right there, the blue diamond is what happens if you use colonoscopy at 50, and the brown square is what happens if you do colonoscopy at 45. And what I'm showing you is there's actually a tiny cost difference. And how do you explain that? Well, as Axel and many of us know, if you're treating a young person, particularly for metastatic colorectal cancer, not only is that hugely tragic, it's also enormously expensive. Like, I can easily rack up a bill, not proudly, of hundreds of thousands of dollars over their disease course. So you kind of have to think downstream when you're adding up, the sums. And making a preventative measure now and saving that money then means actually there's really a very small, I think, difference in cost when you factor all this in. And ultimately, Dr. Lenz and others found that it only costs $14 more to do the colonoscopy at 45 versus 50 when you account from the savings, let alone life years gained, from the additional prevented cases. So that's cost on the payer level or national level. What about cost to the individual? So now I'm going to pivot and talk about some work I've done in Utah. I work in Utah and I love it. And one of the reasons I love it is the youngest state in the nation. So we have many, many young people. My wife's clinic is absolutely overflowing. When we were shopping for houses, the realtor was showing us like 9 and 10 bedroom homes. And we were like, whoa, we only have 2 kids. So we'd see something a bit smaller, please. But the reason it's great is there's all these young people. Well, it's not so great to an oncologist. There's lots of young people with cancer. And we've done work there between my institution and the university to ask them about specifically the burden of financial toxicity, the great sort of unrecognized or under-recognized adverse effect of oncology. And so we use this tool out of Ohio, the Comprehensive Score for Financial Toxicity, or COST. And these are all the questions that they're asked. The main thing I want you to know is when they answer these questions, the lower the score, the worse the financial toxicity. And then what we really were interested in doing is finding where's the cut point in their responses. And it's not entirely coincidental that the cut point happens right around age 25. And I bet some of you already know why that would be. So if you look at the 15 through 25-year-olds and then the 26 through 39-year-olds in the left and right columns respectively, what I highlighted for you are where they have statistically significant differences in their responses to these surveys. And again, remember, the lower the number, the worse they're incurring toxicity. So in terms of being able to meet monthly expenses, feeling financially stressed, reducing satisfaction with their present financial situation through their cost of treatment, and feeling in control of their financial situation. Those are all areas where there was a significant difference between these two subgroups. And then the total cost score, again, lower being worse, was also statistically significantly different, not favoring the older folks. So why this dichotomy? So we can only postulate, but when I presented this work in Australia in December, so there's 3 really big countries in the world that have, I think, devoted particular effort to AYA: Australia, the UK, and the United States. And so when I was talking to my Australian and British colleagues, and again, I'm a British expat myself, they found this pretty shocking, and so I had to explain the backstory of the Affordable Care Act, whereby AYA patients from 2010 forward have been able to get insurance coverage through the parents up until their 26th birthday. And so as of 2016, so from 2010 to 2016, about 6 million young adults had actually demonstrably acquired insurance in this manner. So the problem is, and I've actually got a medical assistant in my clinic who turns 26 this week, and she turned to me last week and said, I'm really scared because my medical expenses are about to go way up. So she's not happy at all about turning 26. So we postulated it's partly this increasing cost concern is actually partly due to added pressure to secure their own coverage from 26 and up. There's other putative factors as well. So this is a very arguably vulnerable time of life. Perhaps people are getting married, perhaps they're trying to start careers, and there's this catch-22 where, if they get sick and they're securing their health insurance through their work, but then they become too sick to work, then you're kind of double jeopardy there. It's penalties on both sides. And then maybe they're having children themselves, and it's a father of 2, not the father of 5 or 6 or 7, like some of the families I see in Salt Lake. Kids are expensive, right? So here are my conclusions. First of all, I'm enormously honored to be speaking today, and David's talk was wonderful, and I'm looking forward to hearing everyone else this morning, so thank you for listening to me. AYA patients are obviously near and dear to my heart. I would argue that they do have different host and disease biology than either their older or their younger counterparts, and part of that is socioeconomic vulnerability. As a tumor-specific exemplar, I know it's not the most prevalent AYA cancer, but I'm very worried about the rate of early onset CRC increasing. I think better understanding of etiology is needed if we're going to risk stratify folks and prevent and do focused screening. And I really do think, in my heart of hearts, that screening initiation for colorectal cancer age 45 should be considered in the average age population. I know it varies across the country, but I see mammography being done at age 40 in many places. I think cervical cancer screening. I think we can learn from the advances we've made in the health of young women and apply it to men and women. The last thing I'll say on a personal note, and I've not been quiet about this at all, I waived confidentiality a long time ago, is I'm actually an AYA cancer patient myself. Now, I've got a lot of gray hairs. Actually, you should know, I recently saw a patient who you and I had seen together in fellowship when I was shadowing you. And you see me now that I'm a big boy doctor. And he walked into the room, and the first thing he said, there's professional decorum on our side, right? But the patients can say whatever they want. The first thing he said when I walked in is, Dr. Lewis, you've aged. And it's like, well, thank you for that. Yeah, oncology, it's like looking at the pictures of presidents, like before and after their presidency. I think 8 years in oncology has given me a lot of gray hair. But this is my last year, technically, as an AYA, so I'm about to age out of my own demographic. So my first week in fellowship, this is my other takeaway from the Mayo Clinic, my first week in fellowship, I actually diagnosed myself with hereditary tumor syndrome. And I remember going to my internist there, and he just didn't believe me. It turns out there's a very fine line between knowing yourself and hypochondriasis, and he was pretty sure I was well on the other side of that line. But no, I twisted his arm and got the testing, and I had MEN1, and I've gone through a series of surgeries, including at Mayo and elsewhere, and 2 years ago now I had a Whipple. And it's really changed my whole perspective on being a young person with cancer. I've been enormously lucky. I've had fantastic mentorship. My job has been incredibly understanding. My wife, as I mentioned, is a pediatrician. She actually dropped an NG tube on me at home, which, talk about like in sickness and in health. It was actually a wonderful moment. So I'd had bear with me. So I'd had multiple returns to the ER for delayed gastric emptying, and I had bilious vomiting. Hope you're done with breakfast. And so I was miserable, and I'm very, very stubborn. And she said, listen, we're either going back to the ER again, or you're going to let me put this NG tube in. And I said, oh, that's fine, okay. And so she's at the bedside, threading it in. Keep in mind, she's a pediatrician. So as she's sticking in this tube, she goes, your nostrils are enormous. And I was like, well, thank you. And honestly, I didn't feel it at all. She's fantastic. So being an AYA cancer patient has a whole other aspect to how you look at healthcare. It's weird, it's isolating almost to be young with cancer. It can affect your career and your job, and it can affect your children too. So the last kind of, attempt to pluck your heartstrings, on the picture on the right there, you can kind of see my boy. So he's got MEN1 as well. So I know there's a small proportion of these cancers that are hereditary, thankfully. And I feel so hopeful in oncology that his life and his health will be better than mine because we're getting better iteratively and because of people like you. So thank you so much for your work, and thanks for listening to me this morning.
Thank you, Mark, for that wonderful talk. I would like to invite David back up here. We have maybe about 5 minutes for questions. We have and we can always have the coffee sooner, I guess, so it'll be okay.
Morning. Thank you for that wonderful talk. Questions for Mark. With respect to microbiome, I recently learned that the microbiome population and diversity is very different between the left and right. What are your thoughts and comments on that and how that affects?
That's very well said. So I work at Intermountain, which is sometimes described as like the mini Kaiser of Utah. And so I think, at least in my institution, we're just in the infancy of even trying to understand that. But what we've started doing is when we do colonoscopies, we've been trying our best, and it's arguable if the methodology is right, to sample the microbiome at the same time. I agree with you, and I'm sure there's people in the audience, and Axel, I'm sorry to keep referencing you, who could comment on this more astutely than I could. But yeah, I think there's something to that. And again, I really think, and I may have just convinced myself of this, but I really think it's going to turn out that our past antibiotic use has something to do with it. And the hard part, right, is tracking that, like, having perfect, not just prospective, but perfect hindsight into it's very, very difficult to remember all the antibiotics you might have received in your lifetime, particularly as a child.
So a quick follow-up.
Yeah, yes.
We know antibiotic use has an impact.
Yes.
What about just diet? Because we know a different variety of diet does actually influence your microbiome.
Yeah, no, absolutely. That's a great point. And then on top of that, there's also the parts of the diet that likely are carcinogenic or could be carcinogenic, right? So I just, a lot of you follow Vinay Prasad on Twitter, who I think is just absolutely fantastic. And he's been rightly critical of the field of nutritional epidemiology having been sullied by either bad science or pseudoscience. I just think doing good controlled studies on diet is enormously difficult. So I think it's really hard to discern exactly what's happening there. But you're absolutely right. I think we, not just at my institution as a whole, I think we're really just on the cusp of even understanding host microbiome interaction, right? And I think, especially in the age of immunotherapy, I think it's just absolutely fascinating. And David, I know the question wasn't for you. I don't know if you have any comments.
Yeah.
Yeah, PPI use as well. That's a very good point.
My question for you is, you touched upon this a little bit, but thank you for mentioning financial toxicity. And you touched upon them asking what stage they're in.
Yeah.
So I'm in the financial space for cancer and see a lot of young adults in financial trouble. And we're seeing that by the time they are diagnosed, it's so late because they aren't, they're out of the house. There's not a parent taking them to the doctors. They might not have insurance. They're more worried about their career. So do you see a correlation between late diagnosis because of financial barriers?
Wow, that's a really, really great question. I've actually thought about this a lot in terms of selling colonoscopy, if you will. So I think the only harder sell in GI than colonoscopy is probably adjuvant chemotherapy. Giving someone drugs when you can't see any cells is quite tricky and takes a lot of artful salesmanship. But the reason I bring it up with colonoscopy is if you think about lost opportunity costs. I mentioned mammography and pap smear, and I think they're wonderful screening tests, but they arguably require less peri-procedural logistics, if you will, than a colonoscopy. And one reason I'm bringing this up is the preventable tragedy I see happening again and again in my clinic is a young man is anemic, has iron deficiency anemia, and that gets written off, and or a young man or a woman has been telling their PCP that they have blood in their stool for years, often without a rectal exam, with the presumption of hemorrhoids or IBD, or even IBS, the latter of which I think absolutely is a diagnosis of exclusion. So here's what I'm getting to with your question. I can't tell you exactly the proportion, but I think some fraction, perhaps a substantial fraction of my young patients actually had symptoms. So we're not even talking about screening at this point, we're talking about diagnosis. And for whatever reason, forewent or were never recommended colonoscopies. And if it's the latter, that's a clinician problem. If it's the former, though, they were worried about taking the time off work to go get a colonoscopy. Because it's essentially, you have to do the prep the night before, and that's no fun. And then the day of, you're probably going to be unable to work that day. And a lot of these people just literally cannot afford to do that. And then the other part is, in terms of social support, you need someone to take you, to and from the colonoscopy, right? And so that's a tough thing, perhaps, to ask a friend, unless they're a very close friend. And so I think there's a lot going on there in terms of young people. I don't think it's just stigma. I think there's this sort of unfortunate series of dominoes falling where symptoms that are red flags get overlooked or swept under the rug or not properly investigated. I think that's both clinician and patient level.
There are a couple of things, and you said you're a financial counselor, and I can tell you that in our clinic, the financial counselor is one of the most important people. Financial toxicity is actually the #1 concern of patients with cancer, above and beyond how long they're going to live, if you look at those surveys. The other thing that I think is really unique is this issue around colonoscopies or anoscopy. Mark, you mentioned that some people don't even do a rectal exam. Well, I can tell you the first time I meet a patient, I never do a rectal exam on them if they're HIV infected, because so many of them have been sexually traumatized. And the whole questions of how you do a rectal exam and approach it. So I wait till I have a relationship with them. So there are unique aspects. My son is 26. He lost his insurance, but he has Crohn's colitis. And it was a huge issue for us. And we were very lucky that we had great social workers in our clinic that we could use in that in-between time while he was looking for insurance.
Yeah, Mark, David, I'm sorry all the questions are for Mark. I don't know if you can answer this from your personal experience, but maybe from being involved. I have a wife and a daughter of BRCA1, and my daughter was diagnosed with breast cancer at age 27. She's trying to move that clinical trial bar. She's in her 3rd clinical trial. But she has found connecting with other young adults who have cancer to be both difficult and gratifying. You kind of have probably your own built-in support group because you're in medicine. But do you find that that the young adults, perhaps part of their loneliness is that they feel so isolated as a young person who's dealing with this and doing it all alone?
Yeah, no, wow, you've hit quite a resonant chord with me there. So again, no disrespect to my Mayo faculty that are here, but being diagnosed with a rare disease, my first week of fellowship actually was very lonely. I didn't know anybody else with MEN1, for instance. And again, you can make arguments both ways about the internet and social media. I've actually found it to be an enormous asset. And so Twitter is great, I think, for having an open dialogue, but say what you will about Facebook. I've actually operated a closed group on Facebook for about 9 years now, almost since my diagnosis. It has about 2,000 members. And it allows you to overcome the sense that you are all alone and also overcome geography. So especially, I realize BRCA has its own horrors, especially if you have a less prevalent mutation or disease. You can really find people there that are kindred spirits. Also, I applaud your daughter for being involved in clinical trials. I think that conversation is actually really important to destigmatize research. I didn't really get into it, but if you poll young adults about the meaning of the word research, not even clinical trial, it's just research, there's kind of a knee-jerk tendency to think guinea pig and last resort as opposed to, potentially being the best and perhaps even the best first thing for them to do, right? So I think that conversation, it can, get off the rails if it's not moderated, but I think the conversation between young adults online is hopefully more positive than negative. And I just wish your daughter the best. The other thing I want to say about having hereditary disease is, so the Genetic Information Non-Discrimination Act of 2008 may have been the last great piece of bipartisan legislation. It was, I think, authored under Bush and signed under Obama. And as a young person, it does protect you in certain ways. It should protect you from being fired. It should also protect your health insurance premiums. It does not protect you, however, from your disability insurance going up, your long-term care insurance going up, or your life insurance going through the roof. So I was in such a hurry to diagnose myself, I didn't think about any of that. And again, I'm not asking for your sympathy, but I think for a lot of young people, that ends up being financially ruinous, particularly the disability part. Because again, if you lose your job because you're sick, you're now stuck from multiple angles. So my thoughts go out to your daughter. Thanks for asking.
Great. Thanks for a terrific session, everybody. We're going to take a 10-minute break.